So I'm going to talk about the impact of age-related decline in fertility and how to deal with it. And before I do so, I would like to start with a little bit of a general introduction about infertility. So if we want to keep things simple, then we can say that there are three things that are needed for a spontaneous conception: regular ovulation, normal sperm parameters, and normal anatomy. The uterus has to have a normal intact cavity, and at least one of the fallopian tubes has to be open. Now, there's obviously a lot more that is needed. First of all, proper timing is needed, because the ovulated oocyte can only be fertilized for a short period of time, which is 1 to 2 days. Sperm maintains its fertilizing capacity for longer, for about 2 to 5 days. If we take all this into consideration and look at the chance of a young, healthy couple to achieve a pregnancy in the very first month or in the first couple of months, then we will see that reproduction is one of the least effective functions of the human body, because there's a maximum about 30% chance per month in the first couple of months to achieve a pregnancy. After about 6 months, about 70–80% of the couples will be successful. And even if an embryo implants, about half of these embryos will be lost. And by the time we clinically diagnose the pregnancy, either by a blood test or by ultrasound, still about 1/4 of the pregnancies will be miscarried. Now, the risk of pregnancy loss is higher among older patients and is lower among younger patients, but there's still a considerable risk of pregnancy loss once an embryo has implanted. So if we look at these numbers, we can say that infertility is diagnosed in those couples who have been trying for a year or longer to succeed. Over the age of 35, an evaluation can be started after 6 months of attempts. And over the age of 40, it can be started as soon as the couple presents for evaluation. And this already outlines that the impact of age is very important when it comes to fertility and infertility evaluation and treatment. So if we look at the causes of infertility, in about 1/3 of the cases, the main cause is on the male side. In about another 30% of the cases, it is on the female side. In about 10% of the cases, problems both in the man and the woman can be found. About 1/4 of the cases are so-called unexplained, when the evaluation reveals no major problems, and 5% are other causes of infertility. If we look at the causes of female infertility, in about 35% of the cases, we will find some problem with the ovulatory function of the ovaries. In about 30% of the cases, the tubes will be damaged. In about 5% of the cases, there will be problems with the uterus, such as fibroids or adhesions in the uterus or any congenital anomaly of the uterus. Endometriosis is another common diagnosis among infertile patients. And about 1 in 5 is the risk of seeing patients who have low ovarian reserve, diminished ovarian reserve, or with other words, who have few eggs in the ovaries. So if we look at the impact of age, then nowadays it is hard to tell couples, because most couples are much older than 20 to 30 years. If, for example, in our clinic, the average age of the patients is around 38, but the ideal age for fertility is between ages 20 and 30. From age 30 onwards, there's a slow decline in the chance of conception per attempt. And this could be spontaneous attempt, insemination, or even in vitro fertilization. This decline gets a little bit steeper in the late 30s and then over 40 again. And by the mid-40s, the chance of conception, either spontaneously or with fertility treatment, approaches 0%. If we look at the same association a little bit differently, then we will see that among couples where the woman is under the age of 35, in about only 4% of them will infertility be diagnosed. By the time they are between 25 and 34, this risk triples, and between 35 and 44, the risk will be 1 in 3. And again, yet another look at the same association. If we look at women who needed insemination using donor sperm, the best success rate was among women who were young, who were under the age of 31. They had 74% chance to achieve after multiple insemination treatments. In the next age group, 31 to 35 years, there was already a 15% decline. And in the over 35 years, there was about a 50% decline compared to the younger patients. So all these associations tell us that the chance of fertility declines with age. And there are two main reasons for this. One of them is that through cell divisions, it is by mid-gestation, so in utero, around 18-20 weeks in utero, that the peak number of eggs in the ovaries is reached, and it is around 6 to 7 million at that point. This is the number of eggs in the ovaries when a female fetus is halfway through the gestation. By birth, the number is down to 1 to 2 million, and by puberty, the number is down to 400 to 500,000 only. So the majority of the eggs were already lost by the time the reproductive lifespan starts. And when the reproductive lifespan ends at menopause, the number is down to a few thousand only. So one of the important tests that we do when we meet a couple who faces infertility is that we try to estimate how many eggs the woman has in the ovaries. And this is called ovarian reserve testing. And a lot of different tests can be done for this. Obviously, the patients do not have to undergo all of these tests. And I highlighted in red the two best markers that indicate the number of eggs in the ovaries, and are the most useful for us physicians because they tell us who is going to have a poorer response to stimulation and who is the patient who is expected to have a very sensitive response to stimulation. One of these markers is anti-Müllerian hormone. This hormone can be measured by a blood test. And the nice thing about this is that this can be measured anytime in the cycle and can even be measured when the patients are taking hormones such as contraceptive pills. The other one is an ultrasound marker when the number of small follicles are counted in the ovaries. And these are the follicles that are expected to grow in the next cycle. And this is called antral follicle count. If we look at the cutoffs, what is considered a low reserve, a normal reserve, or a high reserve, we will get these numbers. The reserve is considered low when the anti-Müllerian hormone level is below 1.1 nanogram per milliliter or 7.8 picomole per liter, or when the follicle count is below 5 and 7. This is the sum of the number of small follicles in the two ovaries on an ultrasound study, and this ultrasound is usually done in the beginning of the cycle. So this is the group of patients that is the most challenging for us. Because with other words, what this means is that these are the patients who put very low number of eggs to the start line when stimulation is started. If someone puts only 2 or 3 eggs to the start line, it doesn't matter how much medication we give or what stimulation protocol we use, the maximum that we can get is 2 or 3 follicles developing at the same time. If someone puts 5 to 10 follicles to the start line, then if we give a proper medication dose and use a proper stimulation protocol, then we can get 5, 7, 8 eggs as a result of the stimulation. Now, the other extreme is the high responder patient. So if this patient puts, let's say, 50, 60 follicles to the start line, then we actually have to use very little medication because we don't want all those follicles to grow. What do we do with these ovarian reserve markers? I always tell my patients that I primarily use these markers to decide on what stimulation protocol and what medications to give them. Rarely I use them for counseling, and I will, in very rare occasions, talk patients out of treatment. So if these values are at the extremes, I may advise them not to try treatment, but proceed with alternative management such as donor oocyte in vitro fertilization instead. I may use these markers for those patients where I hesitate between insemination and in vitro fertilization. So this is a patient in her mid-30s with normal sperm parameters and open fallopian tubes. If she has good ovarian reserve markers, has good number of eggs in the ovaries, I probably will advise insemination as first-line treatment. If she has lower number of eggs and I worry that I run out of time, I may advise in vitro fertilization. I don't use these markers to tell someone that she's going to be pregnant and tell another patient that she's not going to be pregnant, because they do not predict these. These numbers, the anti-Müllerian hormone values and the follicle counts, predict response to stimulation. So this is just a schematic view of a stimulation. And if we look at in the middle of the screen where the 0 is, that's the start of the cycle. So this is the point where we usually start the stimulation. And this is the point when there's a group of follicles that were selected by the body starts its journey to ovulation. Now, if we use proper amount of medications, and there are different medications that we can use. There are some tablets that can be used for the stimulation, but mainly we use injections for the stimulation. So if we select the proper medication dose, then we can get a nice group of follicles grow simultaneously. And when they reach the right size, we prepare them for the egg retrieval. 36 hours later, we try to take the eggs out of these follicles, fertilize them, and a couple of days later, we follow with the transfer. But we cannot use the same approach for everyone. We have to individualize the stimulation protocol, the medication type, and the medication dose. If we have a patient who has a low ovarian reserve, it is always a question whether we can improve the ovarian reserve. A lot of patients ask whether we can improve their AMH level or whether we can change their FSH, follicle stimulating hormone level. We cannot really do that, but there are certain things that we can do to navigate ourselves into a little bit more ideal situation. Weight is a sensitive issue, and there's an increasing proportion of patients who start fertility treatment with excess weight, even with extreme obesity. It's not so much the weight, but the body mass index that we use that is calculated based on height and weight. And the normal body mass index is between 18.5 and 25. And the higher the body mass index is, the lower the efficacy of fertility treatment is. First of all, patients with high body mass index are more likely to suffer from irregular menstrual cycles, irregular ovulation. They usually need more medication during the stimulation, and even with more medication, they are more likely to respond with fewer oocytes, and even the quality of these oocytes is poorer. Therefore, they have a lower chance for implantation, and the risk of pregnancy loss increases. So it is not always the medications that we need to change or the stimulation protocol that we need to change, but there are things that the patient herself can do by going on a diet, starting to exercise, and that is to lose weight to try to optimize her response to treatment. Smoking is another no during fertility treatment. Heavier smoking is defined as smoking more than 10 cigarettes per day. And women who smoke, and the more they smoke and for the longer they smoke, are more likely to have diminished ovarian reserve, because toxins in smoke are detrimental to the follicles, to the oocytes as well. Women who smoke reach menopause 1 to 4 years earlier. So if we consider a 30-35 year lifespan, this means that they shorten their reproductive lifespan by about 10%. Smokers are more likely to have ectopic pregnancies. The risk of pregnancy loss increases. Among men, the semen parameters are poorer. They need more treatments to achieve success. So giving up smoking, or actually not starting smoking, would be ideal, but giving up smoking, or at least cutting back on smoking, can improve the reproductive outcome as well. There are various medications that were given, and their impact on the ovarian reserve was tested. DHEA and testosterone are both androgen hormones, and androgen hormones increase the sensitivity of the follicles to stimulation, so the follicles are more likely to respond to stimulation. Unfortunately, the scientific results are very controversial. There are many small studies that evaluated the impact of DHEA and testosterone on subsequent response to stimulation. And if we try to combine their results, then we will see that they have minimal positive response on the number of eggs that can be collected during in vitro fertilization or even pregnancy rates. However, if we only focus on the good quality studies that were properly designed from a scientific point of view, this advantage is lost. Growth hormone is another medication that is given to try to improve ovarian function. And again, it seems to have a minimal positive impact on the number of eggs that can be collected and through that on live birth rates with in vitro fertilization. Coenzyme Q10 is a supplement that is needed for mitochondrial function. And we know that with age, the number and quality of the mitochondria declines in the ovaries. And by supplementing patients with coenzyme Q10, we try to slow this process down and we try to improve the quality of the eggs. The bottom line is that all these can be attempted, but they don't have a major impact on the ovarian reserve. What is gone is gone. These will not bring those eggs back that were lost from the ovaries. Another interesting aspect is that traditionally we start stimulation for in vitro fertilization at the beginning of the cycle. But ultrasound studies were done that noticed that it's not just one group of follicles that start to grow in one cycle, but sometimes two or sometimes even three groups of follicles can be seen. This opened up ways for so-called non-conventional stimulation, that is stimulation that is not started at the beginning of the cycle. This is primarily good for those patients who need oncologic treatment and they don't really have time to wait for treatment, but they need to start their stimulation right away. They can start it at any time in the cycle, even after ovulation. But the benefit of the 2 or 3 waves of egg development was explored by various groups when they tried to stimulate patients twice. Now, this is a very complicated approach. This is the Chinese approach by Kuang and colleagues. They used stimulation from the beginning of the cycle. They proceeded to egg retrieval. And a couple of days later, they started another stimulation again. And if you look at the table, you will see that these were, first of all, not good responder patients. So with the first stimulation, on average, 1.5 eggs were collected. And with the second stimulation, another 2.7 eggs were collected. So you can almost triple the total number of eggs if you use stimulations twice in the cycle. And you can also increase the number of embryos that are available because as a result of the first stimulation, on average, the number was a little bit below 1. And with the second stimulation, it was 1.3. So you can double the number of embryos that can be created. The problem with this approach is that you need to freeze these embryos and then they need to be transferred subsequently. Another group from Italy also tested a little bit different stimulation approach, and this is slightly less complicated. They used a standard IVF stimulation when they gave patients a high dose of stimulation, combined it with so-called GnRH antagonist that is given to prevent ovulation. We want these follicles to grow and we don't want them to rupture too early, so we need to prevent it with medications, and this is what GnRH antagonists do. Again, they proceeded with the retrieval, waited for 5 days, and started a second stimulation. And again, if you look in the table, you will see that with the first stimulation, they were able to get 4 eggs, and with the second stimulation, another 4 eggs or almost 5 eggs. And they tested the embryos for genetics. And with the first stimulation, 40% of the cases, there was at least 1 healthy egg. And with the second stimulation, in another 40% of the cases, they could add another egg. So trying these non-conventional stimulations may improve the reproductive outcome for those patients who tend to respond poorly with very few number of follicles and very few eggs during stimulation. The other question is whether it is all about quantity, and the answer is a strong no. Quantity is important, but the quality of the oocytes is even more important. I always tell my patients that I much rather work with a young patient who has poor ovarian reserve than with an older patient who has very good ovarian reserve, because I would much rather retrieve 3-4 eggs from a 30-year-old patient and hope for good quality embryos out of them than to have 14-15 eggs at the age of 44-45. The young patient is still a lot more likely to achieve a pregnancy. Now, oocyte quality declines with age. And I usually explain my patients in the following way this. I tell them that when they are young, they tend to recruit those eggs that are very easily recruitable, and those are their good quality eggs. And as they get older, they tend to be left with those eggs that did not want to enter the reproductive process and are very hard to stimulate. And these eggs are less likely to work well. And why is this important? Well, the genetics of the embryo is made up of the genetics coming from the sperm and from the egg. But when the embryo starts to divide, when the fertilized egg starts to divide and starts to increase the cell number to 2 to 4 to A and to many, many millions, there are errors in these divisions. And the early events are guided by genetic material that comes from the mother. So the egg carries the information that will guide the first 2-3 divisions of the embryo. And if the egg is not good quality, then the guidance will be not good quality either. And the embryo will be more likely to be genetically abnormal. And this is a slide that I usually share with my patients. This slide shows the results of genetic testing of over 15,000 embryos. And if you look at the incidence in going from left to right, we see the age increasing from 22 to 45, and going from down to up, we see the percent of embryos that are chromosomally abnormal. We will see that the lowest chromosome abnormality rate is somewhere between 25 and 31, 32. And even in this age group, already about 30% of the embryos will not be healthy, but still the majority of them will be healthy. Now, from the early 30s onwards, there's a rise in the chromosome anomaly rate. And by the age of 44, 45, this gets up to 90% or even higher. So if we take a 44, 45-year-old patient and she produces 15 eggs, out of which we are able to get 10 embryos, only one of those embryos or not even one will be healthy. So even though she responds with a lot of eggs, her chance to have an embryo that is able to implant is very low. So it's not just the quantity, but the quality that is very important. So what is it that we could do to prevent this age-related decline in fertility? One of the options is to cryopreserve oocytes at a younger age. The problem with this is that not too many women in their 20s think about this. And many of those who would freeze embryos in their 20s eventually will meet their partner with whom they will be able to reproduce spontaneously, and they will not need their cryopreserved oocytes. Typically, it is the patient with a more advanced reproductive age that thinks of oocyte cryopreservation, usually in the late 30s or even over 40. And the problem with them is that they need a lot of eggs to be fertilized, because it is usually said that one oocyte has a 5 to 7% chance to result in a live birth. So those patients who end up freezing oocytes in their late 30s or even 40s, they need 20, 30 eggs to cryopreserve to have a real chance at having a child later on. And in order to have 20, 30 eggs, they need to undergo multiple IVF treatments, which is not practical, especially if they have low ovarian reserve and they can only produce 2 or 3 eggs in a cycle. So the other issue is that a small percent of those patients who freeze their eggs return for their eggs later on. So the question is, who should pay for the storage and what should be done with these eggs later on? Oocyte cryopreservation is an option for those patients, again, who face oncology treatment and do not have a partner to be able to fertilize oocytes. And finally, I need to talk about the topic that patients do not like to hear. But ultimately, the treatment of choice for those patients who either have advanced reproductive age or have very poor ovarian reserve is oocyte donation, because this is the only way to replace what is missing. Another example that I tell my patients, because they always ask, can you give more medication? Can we try stimulation again? I always tell them that if you sit in a car that has an empty gas tank, you can turn the ignition key and it doesn't matter how hard you turn it, the engine will not get started. So if the engine is empty, if the gas tank is empty, then we need to replace the oocytes, and that can be done with a third person who should be a young, healthy person with normal ovarian reserve who undergoes the stimulation and provides the oocytes for the treatment. This is highly effective, but it is important to say that there will be no genetic link between the mother who has the embryo transferred and the embryo. So in summary, ovarian supply unfortunately is limited, and we need to do everything to preserve this supply. So maintaining a healthy diet, regular exercise, not using toxic habits such as smoking is very important. There are certain supplements, medications, DHEA, testosterone, growth hormone, coenzyme Q10, that can be attempted, and they will not make the ovarian reserve work. It's questionable whether they can improve the ovarian reserve, but I don't think that anyone has anything to lose by trying these before stimulation is started. Alternative fertility treatments, double stimulation, random start of stimulation can be attempted for patients with low ovarian reserve. And eventually, even more alternative treatments such as oocyte donation may need to be considered. So with this, I want to thank you for your attention, and I will give it back to Dr. Allahbadia. I see that he has joined.
Thank you, Peter. We will quickly finish my talk. Essentially, today the meeting was for patients exclusively. I have seen, although there are a few doctors who have joined in, my talk will take about 20 minutes, and then we will get to all the questions and answers. The rules are that only the questions which are put in the Q&A box will be answered, and please do not raise hands. Whatever you want to ask, you put it in the question and answer box, and we will answer every single question. My talk today is advances in medically assisted reproduction or updates on medically assisted reproduction, what the patients should know. There are some videos for the non-initiated patients who have not undergone IVF to actually show you how the IVF process is done. Can you see this? Japneet, is
yes, doctor. We can see it. Yeah.
Is it full screen? Yeah. Okay.
Yes.
So I've optimized it so the videos are especially clear, and they are short videos. No video is more than a minute. It's just a glimpse into the operation theater or the embryology lab to give them a quick peek into how assisted reproduction is done in contemporary times. So this is a short film that once I switch it on, it's exactly 59 seconds, which shows how an egg is released from the surface of the ovary. It is picked up by the fallopian tube. The egg is propelled inside the fallopian tube around mid-cycle by hair-like structures called the cilia. Then there is a peek into the human testis, into the seminiferous tubules where sperms are produced. A microchip camera along with the ejaculate coming into the posterior vaginal fornix, and then the sperms traveling up to the mouth of the uterus, which is the cervix. These sperms stay in the cervix for up to 72 hours and are thrown up in asynchronous waves towards the fallopian tubes, towards the internal tubal ostium. The sperms meet the egg, which lies waiting for them in the fallopian tube. Fertilization takes place in the fallopian tube, and 4 or 5 days later, the embryo travels back to the uterine cavity and gets implanted. If all goes well, then you have a normal baby coming into this world. This 59-second film is an edited example of everything that I've spoken in the last 2 minutes. So let's watch this. So the traditional approach has to be abandoned for something more aggressive today. Infertility is a common problem. 1 in 5 couple has some problem getting pregnant. It's always important and urgent for the patient. However, most first approach doctors take a wait and watch approach. Often patients get fed up, frustrated, opt out of treatment, change doctors. This is really a shame. Patients, we need to change. Patients are today getting married at an older age group. Like Peter mentioned, the average age of patients in his clinic is 38. The average age of patients in our clinic is above 40. Time is running out as the biological clock ticks on. But today we have the technology to help these patients get pregnant. What are the common mistakes? What should not be done? The couple is never seen together. Husband is in office, wife comes alone and undergoes piecemeal investigations. Husband's semen analysis is performed at the end, 3 months, and then you realize the husband doesn't have any sperms in his ejaculate. Investigations are performed in a piecemeal fashion rather than as part of an overall strategy. They are often done in a slow, time-consuming manner and patients get fed up. What should we do? The patient must be seen together and treated as a unit. First, find out the reason for the infertility. Whatever is the workup or testing must be explained to the patient in simple language and should be completed in 2 months. Simplifying this whole exercise, you need to understand that you need only 4 things to make a baby: eggs, sperms, uterus where the baby is going to grow, and the fallopian tubes where the sperm meets the eggs. The tubes have to be open. So then you need to check for these 4 things. You need to check for the semen. You need to check if the patient is throwing out an egg each month. You need to do an HSG or a hysterosalpingogram to find out if the tubes are open. Follicular studies are done where you track the growth of an egg and the release of an egg at mid-cycle. And if you suspect any problems, you put in a camera in the pelvis into the peritoneal cavity and do a video laparohysteroscopy, which can pick up congenital birth defects and occasionally do treatments for PCO women. Like this is a picture which should not be done. This is over drilling of a PCO ovary. There is some patient who has put up a question in the question and answer box about Mullerian agenesis. Sometimes if the ovaries are high placed up in the brim of the pelvis, we use a laparoscope to do the egg retrieval. And so endoscopy is very part of a fertility clinic. After the workup, we need to have a finite plan of action. The treatment should not be done on an ad hoc single cycle basis. If something is not working in 2 cycles, you move on to a more aggressive treatment. For example, in unexplained infertility, so you can give gonadotropins, try 4 to 6 cycles at home. If you're trying IUI, just 2 cycles with gonadotropins. If it doesn't work, go on to IVF. Do not waste time, especially today when we are getting older patients coming in for treatment. As a rough rule of thumb, if a treatment is going to work, it will work in 4 cycles. Do not repeat IUI again and again and again. We have patients who come to us who have done IUI 18 and 19 times and not getting pregnant. We should just do 2 times, maximum 3 times, and then post them for IVF. Today, you have to personalize treatment. You have to tailor treatment according to the patient's age, medical diagnosis, and budget. Peter has already run through this: female factor, tubal ovulation, male factor 40%, combined 10%, unexplained 10%. Semen analysis, it's an easy test to do, but very easy to do badly. A trained technician is a must. No lubricants, clean wide-mouthed jar, an environment amenable to collection, and the wife or partner might need to go in to help him collect the sample. Again, rough rules that are true even today. If total motile sperm count, so if a sample is say 100 million per ml and 50% are motile, then this man has 50 million per ml motile sperms. So if total motile sperm count is more than 10 million, then IUI with gonadotropins is the answer. If total motile sperm count is between 5 and 10 million, then IVF is the answer. If total motile sperm count is less than 5 million, then intracytoplasmic sperm injection or assisted fertilization is the answer. Please do not mire the patient in loads of investigations. The patient wants to know only if his sperm can make a baby, and IVF is the definitive test of sperm function. Today, with the availability of techniques like intracytoplasmic sperm injection, we can even retrieve a few sperms from the testis in non-obstructive azoospermia or obstructive azoospermia and get the patient pregnant. So what is medically assisted reproduction? In simple terms, we increase the chances of the egg and sperm meeting. What is not happening in the bedroom, we do in the lab. IVF is the final common pathway. It bypasses all hurdles. It's not artificial. We are just assisting nature. And from 78, since the first baby, there's no increased risk of birth defects. Sometimes at webinars, I'm asked a question, but IVF is too expensive. Maybe, but just because the right treatment is expensive does not mean that you keep doing the wrong treatment just because it's cheap. Today, we talk of cumulative rates. So pregnancy with the fresh cycle and pregnancy with the frozen embryos. Often IVF is more cost effective. Patients often ask us, what is your success rate, doctor? For the patient, success rate is either 100% that she gets pregnant or does not. For the clinician, it's more complicated since we are dealing with patients, types of patients, age of patients, type of lab, the embryologist in the lab, and the training level of the physician. To take the people who have not gone through an IVF cycle, there are 4 basic steps. First is superovulation, meaning every month a woman makes 1 egg. For IVF, we aim for between 10 to 15 eggs. That is called superovulation. We use fertility injections for this. The second part is egg collection or transvaginal ultrasound guided egg retrieval. In vitro is outside the body, so fertilization outside the body. And the 4th part is embryo transfer. So when you give fertility injections, this is a stimulated ovary. These black spaces are fluid-filled areas which contain a microscopic egg each. On the day of the egg collection, we collect the sperms, husband collects the sperm, and the sperms are processed by cleaning them up. You have the good, bad, and ugly sperms in simple terms, and only the good quality sperms, actively forward progressive sperms, are separated from the bad and ugly sperms which are discarded, and you have a final process sample like this. This is an interesting film about how an egg collection is done under vaginal ultrasound guidance. So there is a needle which is put in through the vagina. There's single puncture in the vagina, then it goes through the surface of the ovary and travels from follicle to follicle, aspirating it. the follicular fluid is handed over to the embryologist, who separates the egg from the follicular fluid and then combines it with the sperm to make a baby. After the egg and sperm are put together in 24 hours, you see the fertilization, and then subsequently you see the cleavage and division of the embryo. In our laboratory and most modern laboratories, we culture the embryo to day 5, which is a blastocyst. And last 10 years, I've done only a single embryo transfer. Most modern clinics do a single embryo transfer. Multiple gestation is twins are considered a complication of IVF. And the last part is the embryo transfer, which does not require anesthesia. It's done under abdominal So we always do a blastocyst transfer because of high implantation rates, the improved selection of viable embryos. It is the Charles Darwin's theory, the fittest survives. So some embryo which has survived 5 days of growth outside is always better than doing a day 2 or day 3 transfer. I call this the mother-in-law slide. There is no need for bed rest. You cannot cough the embryo out. It's still a matter of luck. Not the patient's fault if she does not conceive. She cannot reject the embryo. Like with every medical procedure, there are risks of IVF. The biggest risk is not getting pregnant. Multiple pregnancy is considered a complication. Very rarely we get to see ovarian hyperstimulation nowadays. What are advanced medical assisted techniques? So ICSI, which is assisted fertilization, where a single sperm is injected into an egg. I'll show you a film. Assisted hatching, we will see this assisted hatching. We can see the laser being used when we do show you the PGTA films. And let's see this ICSI assisted this is how ICSI is done. Assisted hatching is with the laser. We just crack the outer surface of the zona, the covering of the advanced maternal age, thick zona, repeated implantation failures. Peter showed you a slide in a different way. So this is a slide with over 100,000 embryos where it is age distributed. And in IVF, if you do the age distribution, if you see between the ages of 40 to 41, nearly 80% of embryos are abnormal in routine IVF. And at 40 to 43, almost 90%, and above 40, 96%. So this tells us the importance of pre-implantation genetic testing for aneuploidy, for weeding out abnormal embryos in advanced age groups. This is how a pre-implantation genetic testing is done. This is the hatching blastocyst. This red dot that you see is the laser that is used to separate the selected cells from the main embryo. Let's see this. This procedure PGTA. So 4 to 6 cells are sent for testing, pre-implantation genetic testing for aneuploidy. We do a 24 chromosome testing using NGS. And why do we do it? Because in the shortest possible time, we want to get the patient pregnant. And you can eliminate the freezing of embryos that are chromosomally abnormal and only freeze the normal embryos and get high pregnancy rates. And since we do a single embryo transfer with PGTA, our rates across all age groups are in excess of 60%. So what is PGTA useful for? Even in normal good prognosis patients, it can increase the pregnancy rates from 40% to 70%, male factor from 40% to 65%, recurrent miscarriage from 35% to 60%, implantation, previous IVF failures from 25 to 60%, and advanced maternal age from 20% to 50%. In other words, 2.5 times higher in older age groups, 2.3 times higher in previous IVF failures, 1.7 times higher recurrent miscarriage patients, and 1.6 times higher success rates with male factors. So we can reduce the time to a live birth when we select only euploid embryos, reduce the incidence of miscarriage, transfer in a single euploid embryo, minimizing the risks of multiple pregnancy. When we talk of PGTM, pre-implantation genetic testing for monogenic diseases or single gene disorders, we can prevent these diseases from going down the family tree. And common diseases are thalassemia, cystic fibrosis, sickle cell anemia, many types of muscular dystrophies, myotonic dystrophy, fragile leg, spinal muscular atrophy. So what is the promise of medically assisted reproduction? We can help any couple to have a baby no matter what their medical problem. I practice in a Muslim country where no third-party reproduction is allowed. So no donor sperm, no donor eggs, no surrogacy, no embryo adoption. We deal strictly between husband and wife. And no cycle can be initiated without a marriage certificate. But other countries have more liberal laws and allow donor sperms, donor eggs, surrogacy, and even embryo adoption. So who is an ideal doctor? Don't tell the couple what to do. Let them decide for themselves, so their peace of mind that they their best. For the doctors attending this, if they want to read more about the subject, I've edited or written more 33 textbooks, and our team you can find them on Amazon, and our team can help you locate them.